day everyone, I am Sophia Michibiayay, and for today's video we're gonna perform enterotomy. Enterotomy is an incision into the intestine. The most common indication in small animals is to remove intraluminal intestinal foreign bodies that causes obstruction. It is also performed as a biopsy technique and to examine intestinal lumen for evidence of mucosal ulceration, strictures, or neoplasia. These are the following equipments. Pre-surgical techniques include signalment and test profile, localization of the lesion using abdominal palpation, radiographic imaging and ultrasound, correction of fluid abnormalities. The animal must be fasted for approximately 12 to 18 hours and administer prophylactic antibiotics if indicated. Using a number 11 scalpel blade, fingertip grip, a ventral midline laparotomy incision is made from the xiphoid to the pubis. The entire intestinal tract should be evaluated to determine the number of foreign bodies and assess the viability of the bowel wall. A Balfour retractor is used to retract the abdominal wall and provide adequate exposure of the intestines. So after we have located the intestines, we can already differentiate the normal anatomic parts versus those that are obstructed. So intestinal contents are milk 10 cm to either side of the foreign body, and the bowel is held with Doyen intestinal forceps to minimize spillage. Here, the affected bowel segment is isolated from the remainder of the viscera with saline-soaked laparotomy sponges. After placing the sponges, a number 11 barred Parker scalpel blade is used to make a full-thickness longitudinal incision in the anti-mesenteric border of the intestine. The ideal incision is the healthy tissue proximal or distal to the foreign body. Enlarge the incision as needed with Metzenbaum scissors. The length of the enterotomy approximates the diameter of the foreign body. Continuous suction is used to reduce spillage, and the surgeon pushes the foreign body gently through the enterotomy. Make sure not to tear the incision margin. The foreign body is then removed. Rinse the enterotomy site thoroughly with warm saline. So make sure to examine the bowel lumen for evidence of perforations or strictures before closure. So closure of the enterotomy incision is usually performed with a simple interrupted suture pattern in side-to-side longitudinal fashion, using a 3-0 or 4-0 synthetic absorbable or monofilament non-absorbable suture material on a swage-on, taper point, or taper cut needle. Suture bites are taken perpendicular to the bowel wall 2 to 3 mm from the cut edge and 3 mm apart. So single-layer closures are recommended because double-layer closures may cause excessive narrowing of the lumen diameter. After closure, a leak test is done using a 10 to 20 cc syringe, approximately 22 to 23 gauge needle containing warm saline, and is injected through the intestines in order to make sure that there is no leakage between the intestinal closures. After closure, an momentum patch is applied to reinforce the suture line. This will help prevent leakage a pedicle if greater momentum is wrapped around it. So some severely debilitated patients may benefit from placement of a jejunostomy tube for a postoperative enteral nutritional support. After that, remove all the contaminated materials and then perform routine closure of the abdomen. When spillage occurs, a parenteral antibiotics are continued for approximately 24 to 48 hours post-operatively. That's all. Thank you.